Today we'll be talking about the anterior stability test, also known as the dorsal glide test. This is a test to assess for lumbar instability. Indications for this test are signs of lumbar instability, including intermittent back pain, pain with prolonged positions, including standing or sitting, pain that is relieved with non-weight bearing, reports the back catches, cracks, snaps, or becomes loose, and an observation that the patient braces their low back when they move into or out of flexion, either with excessive motion of the pelvis or bracing themselves with their upper extremities on their thighs.
Some of the contraindications to this test would be recent fractures or contraindications to passive movement throughout the spine, hips, and knees. Also neoplasms or cauda-equina lesions. The biomechanics of this test involve the patient in sideline and their hips flex to different levels depending on which lumbar segment you're looking at. For L1 and L2, you would want to flex the hips to 100 degrees, and for L3 through L5, you want to flex the hips to 70 degrees. This is done to prevent tightening of the posterior lumbar ligaments, particularly the supraspinous ligaments. This would prevent movement of the desired segments and could create a false negative test.
The psychometrics of the anterior stability test have not been assessed. However, other tests that look at lumbar passive motion have been examined, and these have shown a poor interrelator reliability and a poor sensitivity. There's a greater interrelator reliability with hypomobile segments as opposed to hypermobile segments, yet findings are inconsistent when compared to dynamic MRI. However, pain provocation is shown to have a greater reliability than assessing mobility.
A positive test would include reproduction of the patient's pain or symptoms that they came to initially see you for, or increased mobility at the assessed segments, where there should be little to no motion at all. Okay, on the skeleton here, we're going to demonstrate the bony landmarks you'd be palpating on your patient and showing the direction of force you'd be applying through the femur. So in this situation, we're going to start by looking at mobility of the L5 segment. So you'd come over to the back of your patient, you'd palpate the L4, L5 interspace, and you take your top hand and you would place it on L4. At this time, you would then use a pincer grip to stabilize the L4 segment, and you'd come down to the femur. Once you're down here, you're going to bend their hip up to about a 70-degree angle, so right about here. You would try to get their knee kind of in the fold of your hip, so you can use your thigh to apply the force. You're going to take your bottom hand and feel the segment and the space that you're trying to assess, and you'd apply a force this way along the line of the femur, like so. If you wanted to look at an upper lumbar segment, so L1 or L2, you would do the exact same process. You would just flex the hip up to 100 degrees instead of 70. You would again stabilize the top segment with your top hand in a pincer grip, and you would use your bottom hand to palpate the segment and the interspace, with the force again going along the line of the femur, like so.
So Alex, we think that the problem might be with your low back, that it's moving too much, and I want to do a test to find out if that's the case. It's called the anterior stability test. So if you could lie down your side, and I'm going to put my hands in your low back. I'm going to start with the lower segment, your L4 segments. I'm going to put my hands right here, stabilize the segment right below it, bend your leg a bit, and feel for any motion, pushing back. Did that reproduce any of your symptoms, Alex?
No.
Okay, so I didn't feel excessive mobility, that would be negative. And then if I felt up for a higher segment, so right here, that would be your L1, which I'd stabilize to see movement at segment right below it. And again, same test, a higher segment. Did that reproduce any of your symptoms, Alex?
No.
Okay, so we would call that a negative test. Again, a positive test would be if there was excessive motion or if it reproduced any of your symptoms. And we would also see where the symptoms occurred if it wasn't your low back to make sure that was where the problem was located.